I'm going to show you the CVDAction dashboard with dummy data. CVDAction brings together key indicators for the 6 high-risk conditions that cause cardiovascular disease. It brings together around about 85 searches and integrates them into a dashboard. It's built to a national standard reflecting CVD Prevent using the same indicators and code sets. And has been tested for accessibility and in terms of colour. The purpose is to help clinicians translate, bring together lots of complex population health data and information, but to bring that together into actionable format, allowing clinicians to identify individual patients, prioritize workflow, focus on multimorbidity, but to deliver practical action that will optimize care. And the overall objective is to use this focus and prioritization to try and get a step change in population health impact. In other words, preventing heart attacks and strokes at scale. So and our question is, does this complement, add value to local population health systems, and how can it be embedded in those systems to best align? So this is the home page. It shows the 6 conditions in 6 panels, and this gives a population overview for practices. Each of the bars represents not single indicators, but groups of indicators. So, for example, in the hypertension panel, we can see 340 patients not treated to target, 470 patients with hypertension whose CVD risk management, their lipid management is suboptimal, 77 patients who CKD is not being appropriately managed, and there's a case finder at the bottom, 240 patients with possible undiagnosed hypertension. And you see the same sort of approach with AF, cholesterol, chronic kidney disease, diabetes, and non-diabetic hypoglycemia or pre-diabetes. There's a demographics button at the bottom. If I press on that, it'll show the demographic spread across the conditions, and I'll show you that a little later. On the right, there's a help panel, and again, I'll come to that later. At the top, each of the conditions is listed with a button. Press on the hypertension button, and it takes us to the hypertension dashboard. So there are 4 domains here: blood pressure not treated to target, lipid management in patients with hypertension, that broader cardiovascular risk, pulse checking on an annual basis for AF detection, and CKD management in hypertension. So in the hypertension not treated to target, I can see there's 10 patients in my practice whose blood pressure is above 180, and a further 36 whose blood pressure is between 160 and 100. If I click on both of those, then I will be able to see the whole list of patients. And then I come down to the bottom, click on Show Patients, and then I will immediately see all of those patients, 46 patients with blood pressure above 160. So easy to action in that way. And in fact, if I click on bring in those other blood pressure groups as well, so this is everyone with poorly controlled hypertension in practice. If I then go down to demographics at the bottom, hopefully that'll stop worrying now. So this is a demo, and clearly it'll be faster on local servers. But if I click on demographics, and you'll see we have a breakdown by gender, age, ethnicity, deprivation quintiles, and severe mental illness or learning disability. And we can see that there are 12 patients with severe mental illness whose blood pressure is poorly controlled. So we can focus on health inequalities by identifying that list of patients easily and bringing them in for review. Now, in the second panel, this is broader cardiovascular risk management. The first group, patients with hypertension and CVD who are not on lipid-lowering therapy, and then patients who are on suboptimal statin doses or on maximal statin doses, but non-HDLC not treated to target. And then there's patients with hypertension and a Q risk above 10% or who've not had a Q risk. So we can break it down into groups, manageable populations of patients. We can decide how to prioritize and who to review and in what order. Now, if I just show you something else we can do with the filters. So, excuse me, just while this was. So I'm just going to cancel 2 of those filters on the left. So I've got patients there, so with blood pressure above 140. Let's take out that one. So it's patients with blood pressure above 160. And if I then look at the 2 cohorts of patients with cardiovascular disease and suboptimal or no lipid-lowering therapy, and then my patient list at the bottom will be all of those patients, very high risk. They've got significantly high blood pressure and they've got CVD without lipid-lowering therapy. So it immediately helps us to prioritize a group of patients in whom it will make a big difference if we optimize their care. So let me just close down these filters. The AF domain identifies patients with hypertension who've not had a pulse check in the last year, so identifying potential atrial fibrillation, and then patients with both hypertension and CKD who've either not had the blood and urine tests or they're not on appropriate therapies. So if I move to the atrial fibrillation dashboard, you'll see a similar approach. So high-risk atrial fibrillation not on anticoagulants, or patients who haven't had a CHA2DS2-VASc score done, patients whose monitoring is potentially due, and then the broader cardiovascular risk management in patients with AF plus hypertension whose blood pressure is not well controlled, or AF plus CVD who are not on appropriate lipid-lowering therapies. And again, they're chunked up into manageable groups of patients so we can prioritize. We don't have to consider them all in one chunks. So we turn this into really actionable data. So we move on to the cholesterol one now. There are 4 domains in the cholesterol dashboard. Secondary prevention, patients with CVD who are either not on lipid-lowering therapy or the suboptimal dose, or they've not been treated to target. And this top group is 78 patients here with cardiovascular disease, not on any lipid-lowering therapy. In this one practice, and we'll have a list of patients at the top, at the bottom, if we call these patients in and we only get half of them onto statins, that could be expected to prevent 4 or 5 strokes in the next 5 years, strokes or heart attacks in the next 5 years, just in this practice alone. And there's a monitoring domain, so patients with CVD who've not had the appropriate lipid tests in the last year. Primary prevention focuses on Q risk of above 10 or 20% and whether they're not on appropriate statins. And again, you see the approach, chunking up into manageable groups, cohorts of patients, so we can see how to manage our workflow. But in a safe way. And then familial hypercholesterolemia includes a case finder for patients above or below 30. Case finder, these are people who ought to be assessed further for potential familial hypercholesterolemia. Chronic kidney disease, have the patients had the appropriate monitoring? Have the patients had tests for proteinuria, and if they have got protein in the urine, are they on the appropriate treatment? And you can see this is divided up patients with an ACR above 70 or 22.6, according to NICE guidance, patients with CKD and hypertension or diabetes, different levels of ACR that would merit adding renal angiotensin antagonists to their treatment. And then this bottom group, we can click on this and identify the patients with CKD who ought to be considered for SGLT2 inhibitors. And you can see that list of patients there. CKD also includes accelerated progression, so identifies patients who've had a rapid fall in eGFR in the last year, who are urgent for referral for specialist care. And then again, the broader cardiovascular risk management in patients with CKD. So patients with CKD and hypertension, is their blood pressure well controlled? It varies depending on the ACR level. Patients with CKD and cardiovascular disease, again, are they on lipid-lowering therapy? Are they on suboptimal dose or intensity? Are they just not treated to target and should be considered for inclisiran or other similar drugs? And then there's a primary prevention one too. At the bottom, we see a case finder here, which we can click on. This identifies patients who are not on the CKD register, but whose last 2 EGFRs suggest that they ought to be assessed for it. The same, there's a case finder for hypertension in the same way, at finding patients with raised blood pressure who more than 3 months ago who ought to be considered for assessment. Then the diabetes, 4 panels here, identifying my patients with diabetes not treated to target. So the top one is HbA1c above 58, the next one above 75. So that depends on levels of frailty. Patients with suboptimal blood pressure management, again, that varies with age, and also with the presence of proteinuria in patients with type 1 diabetes. So all of those groups there, again, chunked up into manageable groups of patients so we can focus in and optimize care at scale. The second domain is identifying patients who've not had all their 8 care processes, but specifically those patients who've not had an HbA1c done in the last 12 months, because clearly that's a priority. Diabetic kidney disease will identify patients who've just not had the testing in the last 12 months. Patients, again, with a potential accelerated progression of their EGFR, and patients with diabetes with proteinuria who are not on appropriate renal angiotensin antagonists. And there's a case finder for people with CKD in diabetes also. And then the final domain is broader cardiovascular risk management in diabetes, as we mentioned before. But again, here we can focus in on those patients who should be offered SGLT2 inhibitors, 123 patients there. So again, manageable chunks, identifying the most important things to focus on. The final dashboard, which I won't labour, but it's simpler with non-diabetic hypoglycemia or pre-diabetes, but the same approach to identifying suboptimal treatment of both the underlying condition and the broader cardiovascular risk management. So if I just go back to the hypertension page now to just finish off and tell you about the help panel on the right here. So this is present on every dashboard, every condition. The top button, if I press on that, in the same window, it will open up some clinical guidance. This is really, it's not clinical guidance so much as next steps. So what do I do? How do I know what to prioritize? What does it mean if blood pressure or lipids not treated to target, etc.? What are the next steps I should take? Just to make that all very clear, linked to nice guidance, of course, and only reflects that. On each page, there's also a video by Steve, our developer, that gives a brief overview of how to navigate the dashboard. People may want to use that once. There's also a sort of map one can click on to quickly remind you of what all the various bits mean and what different clicks achieve. There's a link section, which we would expect to be filled with local guidance and pathways. At the moment, it has some UCLP resources and then the relevant NICE guidance, but we would want to see adapted locally, of course. And then the final button is just clarification of the definition of each of the So I hope you found that helpful. The purpose of the dashboard is to help us prioritize, help us to focus in all the wealth of population health information that we have, know where to focus in on, so that we can take important action for patients, and know that if we do that at scale, it will deliver population health impact at scale with prevention of heart attacks and strokes. So thanks very much indeed.